but in Zoom. This trial lecture is approved by the committee. The candidate will defend the thesis in a digital defense. Between trial lecture and the defense, there will be a break. I now welcome the candidate to share the screen with us and present the trial lecture with the title Challenges of Initiating and Conducting Randomized Controlled Trials in a School Context. The word is yours, Nsangi.
Thank you very much, the Chair, and to the entire team. My name is Atle Nsangi, a PhD fellow at the University of Oslo and a health systems researcher based here at Makerere University College of Health Sciences. In my trial lecture today, I'm going to discuss the challenges of initiating and conducting randomized control trials in a school context. So I'll briefly introduce randomized control trials and then go on to discuss commonly used randomized control trial designs in a school context. I'll use the consort statement as a framework to identify items that render unique challenges for trials that are conducted in schools. I'll then separately discuss challenges for initiating and as well as challenges for implementation before I conclude the lecture. So what do we know as randomized trials? So randomized trials is a type of scientific experiment or study that's conducted to assess the effects of an intervention. Participants are usually randomly assigned to two groups. One that we commonly call the intervention group that receives the treatment, as well as the comparison group that most of the times or sometimes follows the usual care or sometimes a placebo. So randomized control trials are sometimes individual randomized control trials or cluster randomized control trials. In individual randomized control trials, it's usually individual participants that are randomly allocated to either the intervention or the comparison group. And this type of design is common in clinical settings where the intervention being tested could be, say, a drug or a surgical procedure that can directly be administered to the particular study participant. And in that case, outcomes are usually measured at an individual level. That brings us to the second type, which is the cluster randomized trial. So a cluster randomized trial is one in which intact social groups of individuals sometimes are randomized either to the intervention or control group. And in cluster randomized trials, which are commonly used in school settings, usually the interventions are things like teaching strategies, which by nature can only be applied or tested at a group level. The outcomes to measure the effect of the intervention are still assessed at the individual level. For example, scores in, say, science or math. But at that level, at the level at which the comparison is made is at the group level. So when you're making the comparisons of whether one group performed better than the other, you're likely to be comparing that at the group level. So for example, if, say, we are interested in finding out if a particular treatment strategy is effective in teaching, say, science compared to usual practice, we may want to compare students' performance in the schools that use that strategy that we are testing and those that continue to follow the normal sort of curriculum. We can do this by looking at, say, the average science score in both groups, and we'll be able to see which of the two groups has performed better than the other. Randomized control trials are also sometimes called group trials or community trials. So when should we think of doing cluster randomized trials? Whenever we're dealing with the assessment of group effects of interventions in pre-existing groups, such as schools, hospitals, cities, towns, and the like. So, for school trials, we would typically be doing cluster randomized trials, mainly because, as I said, schools are already pre-existing clusters of individuals, likely to be similar in more ways than one in their characteristics. I know that we might have some beautiful examples of naturally occurring clusters, like if you know, like bird flocks. I think we could use that example to talk about what clusters exist naturally, and schools could be that. So why do we conduct, or why do we use cluster randomized trials? And one of the reasons we end up doing cluster randomized trials in school, it's an effective way to avoid contamination. And avoidance of contamination is one of the most common reasons that this particular design is chosen. So you may ask yourself, how does contamination occur? So contamination can occur if an intervention is given to some group in the intervention group, but its effects end up rubbing onto those in the comparison group. For example, if like individual students within the same school were randomized either to the intervention group that received extra remedial materials to improve maybe say math or science scores, or to the comparison group that continues with the curriculum as normal, you're likely going to end up with a situation where students, say in the intervention group, choose to share their materials with those that were allocated to the comparison group. That's a likely case scenario, and that leads to contamination. But it could also occur if, a contaminated intervention group occurs in ways like students in the intervention group choose not to use those materials because, as you know, in most cases students are peers and they tend to copy behavior from their peers, so that those in the intervention group might decide not to use those materials. That is also an example of contamination. So cluster randomized trials are also done as an effective way to assess treatments administered at a group level. In case you want to assess maybe how the group has been affected, then your best option is doing a cluster randomized trial. So those are the main two reasons. I think it should also be noted that there is currently an upsurge in the use of that design, generally, both in the clinical context as well as in the educational context. And in the clinical context, this trial design resulted from, was adopted mostly during the time of HIV, when there was issues with contamination or infectious diseases. So people in clinical context, especially working with infectious diseases, have chosen to use this sort of design. So when you're considering to do a cluster randomized trial, there are some limitations that you should consider. And one of them is selection bias, which occurs when study recruiters selectively enroll participants into either the trial based on like the next treatment allocation, and what the next treatment allocation is likely to be. But randomization, however, distributes participants' characteristics equally between the two arms when baseline imbalances occur at random. Although the imbalance may not affect trial outcomes, if particular characteristics are substantially not greater in one arm, it can lead to substantially biased estimates of treatment effects and sometimes misleading conclusions. So, like I said when I was starting the presentation, I'll go through these challenges, starting with the initiation challenges before I discuss the implementation challenges. And one of the initiation challenges that we are likely to face when we choose this type of trial design is participant recruitment, mainly because this occurs in two folds. So it's a twofold recruitment process, and therefore requires one to recruit schools as well as teachers and students within those schools. So you're not just recruiting the buses, but you're also recruiting the drivers and the students within those buses. So that's how we would call it a twofold recruitment process. So it's a process that happens in different phases. We do start out with the broader phase, which is the engagement level. And this is where the researchers have to engage people that we generally call gatekeepers. And gatekeepers could be regional education authorities, curriculum specialists who might want to look at whatever intervention it is that you're introducing in schools, and then educational services interest groups, which are common in certain contexts, like in this case in low-income countries. Special interest groups would be, say, people who have disabilities or children who have disabilities, as well as those that are found in internally displaced camps, or normally referred to as refugees. So the recruitment process, as I said, goes through several stages, starting with that one. The second phase is which comes up as the actual recruitment level. So the first one is the engagement, and you're not really seeking consent per se, but you're seeking approval for them to let you be able to conduct that work in their communities. But the second phase, which is the recruitment phase, involves people like head teachers if you are working with schools, and in this phase you could also say principals who grant permission for the school on behalf of the school to participate. Then we further engage the research participants within those schools. So that's now we're getting into the concept level. And the research participants could include people like teachers, students, and maybe other administrators that usually deal with students, depending on what your intervention is. Will have to give you consent, and they could either consent to participate or consent or decide not to participate. And then we lastly have the information level. So the information level, because schools are operating in a multifaceted context, they don't stand as independent sort of initiatives. Schools usually have, say, parents who are users, not necessarily users, but stakeholders. They also have sometimes, in this case, funders. If they are privately owned, they have school owners. So all those have to be informed of whatever it is that you're trying to get done in their schools. And while they might not be giving consent per se, their exclusion makes this whole process delicate because they have a role that they play. So the participant recruitment schedule has to align with the school calendar. So that's the other challenge we come up with when we are recruiting in schools, when we are recruiting schools to participate in cluster randomized trial designs. The research study recruitment timelines need to align to the school calendar, because misaligned recruitment schedules are costly, they're usually very time consuming, and at times significantly hinder research progress. In a study, I could give you an example. In a study it was for the uptake of a preventive treatment for intestinal schistosomiasis in a primary school in Uganda. Researchers had planned to recruit participants, so they had planned to obtain consent, going through the different levels that I've talked about. And then they had also planned to sort of do diagnosis and treatment within those schools that they were working in, or in which the study had to be done. The researchers worked closely with the school administrators in those schools that they were working in to ensure that the research process is properly aligned to the school calendar, because failure to do that, to adhere to a strict timeline, would have hampered research progress in several ways. For example, it could have been impossible to trace in case you had either to give the treatment after the school had closed. It would have been impossible to trace those children, although ideally most of them lived in a 5-kilometer radius. So you need to be very careful when planning to do a cluster randomized trial in a school context to align your research program with the school calendar. And then, like I said, the recruitment process itself is cumbersome, and the reason for that is because it's time-consuming when you do have to deal with the multiple administrative and implementation levels. The second challenge is ethical considerations. Again, just like the recruitment process, cluster randomized trials require a multi-tier consent process, and it involves several levels of approval and consent, like I discussed in the recruitment process. Again, for the involvement of the community in the trial, entry is permitted by what we call the gatekeepers, and this could be, say, the education authorities in the region or the curriculum developers that give approval. And in many cases, in several contexts, you'd have to present this sort of approval to the school authorities. So while school authorities such as head teachers grant permission to recruit their schools into the study, before they do that, sometimes they need to be comforted that the study has gone through the various stages of approval that it needs to go through. And then research participants such as teachers and students need to consent to participate and assent if the student is a minor. And then regional educational authorities such as gatekeepers, irrespective of regions, wherever they are coming from, they need to give approval in order to decide whether the regional participation in this process is sort of beneficial or not. So now when you're thinking about this process, you should be thinking about it like a cake. For those that love cake, I think it would be easy to remember. So when you're dealing, the first top tier is the one that deals with the education authorities. The second one is the one that deals with the school authorities, head teachers, principals, sometimes called school directors. And then the third one is the base, which deals with the research participants themselves. And then we get to obtaining consent. So informed consent is a central protection for research participants. It's a procedure through which a competent research participant, having received and understood all research-related information, can voluntarily provide his or her willingness to participate in a trial. It could be a clinical trial or in a community trial. So researchers in school contexts must obtain informed consent unless you have been granted a waiver. When we do apply for ethics approval, we do so through the research ethics committees of the different institutions in which we operate that may approve a waiver, usually for the following reasons. One, if the trial is not feasible, as an example, it's not possible to consent all trial participants. The trial is not going to happen if we do decide to do that. Then they might grant a waiver. Or if study participation poses no more than minimal risk. So provided they pose only a minimal risk, interventions delivered in clusters or whole communities usually qualify for a waiver of consent, as all cluster members will eventually receive, and sometimes refusal to participate or consent in most cases tends to be meaningless. So the consent process is extremely time consuming, And again, for reasons based on the different levels that you have to go through to obtain approval to work with the group that you're interested in working with. Consent sometimes comes with consent bias, and this will occur if part of the eligible research population does not consent to participate. And I could give an example of a study that was trying to build tolerance and inclusion in madrasa schools that usually follow the Islamic curriculum, where the schools were randomized to a comparison group that was to follow the usual madrasa curriculum, and the intervention group which had to follow the madrasa curriculum in addition to a joint religious intervention. So significantly more schools in the intervention group withdrew their consent once they knew what the intervention was. They decided not to participate. And in this case, the trial had to be stopped because of a significant imbalance in the number of schools that had withdrawn their consent in the intervention arm. When you're dealing with cluster randomized trials, the other issue you have to be thinking about is sample size. So what drives the power of cluster randomized trial is in the number of clusters, not the individuals. So when you're designing a cluster randomized trial, sample size should be one of the things you should consider, because inadequate sample size reduces the power of the study and reduces the ability to quantify the effect accurately. So we would need to focus on having more clusters, or lots of clusters. That means more schools, to allow for unavoidable cluster losses. But we also have to be very careful about unnecessarily large cluster sizes. Those results in unnecessary wastage of resources, usually with no added benefit. So due to the clustering effect, when randomized trials end up with excessively large clusters, such that not all observations within those clusters make a material contribution to the power or precision of the trial, it is therefore vital that the skills of a biostatistician are available at the early stages of planning a cluster randomized trial design and during analysis. But of course, due to the limited availability of such skills, that is also going to be problematic. The other issue is logistical challenges. Now, because cluster randomized trial design entail large groups of, numbers of participants, this comes with additional administrative costs resulting from the management of the numbers of schools that you've recruited, in addition to the participating individuals within those schools. So this study design requires efficient utilization of resources and leaves almost no room for error. Researchers need to keep clear records of what has been done, when, and that helps to avoid mix-ups. I could give an example. Sometimes maybe in this context, but I'm sure in other places as well, there are schools that tend to have similar names. There's a name that maybe is very popular, say St. Mary's or St. Joseph's, and usually what differentiates those schools is the location. So if you're not very careful of which of the St. Mary's, say St. Mary's Nairobi or St. Mary's Kampala, which of the St. Mary's is in the intervention or control group, you might end up mixing those two. And when you do that, you're likely either going to have to exclude them. And as I said, clusters are so important. So losing clusters in cluster randomized trials is a problematic issue. That ushers us into the implementation challenges. And the implementation challenges here start with the interventions themselves. When you're developing an education intervention that is acceptable, practical, deliverable, and measurable, it requires most times the involvement of other end users. Like we said, educational institutions do not operate in a vacuum. So while you might be thinking of developing an intervention for the student, that student does not come as an individual. They come with their parents behind them, they come with the communities, they come with their teachers. So there are a lot of things you need to put into consideration when you're developing interventions for school contexts. But then the other thing as well is you also have to consider the different levels. Sometimes interventions could pertain not just to the cluster level, but to the individual participant, or even both, which usually results into what we call complex interventions that are usually challenging to implement, and in fact, sometimes later on very difficult to replicate. Again, education interventions, not only are they complex, but they're expensive due to their multifaceted nature that I've tried to explain. The issues range from delivery of the intervention itself, the dosage, to allowance of flexibility in terms of how, because they are going to be introduced in real life contexts, there should be some allowance for flexibility in case that's what's needed for them to be implemented. The second challenge with that type of design, the cluster randomized trial design in schools, is it's almost impossible to blind. And as we know, blinding is the process of withholding knowledge of the allocated intervention from the study population. And blinding is actually a key consideration when designing randomized control trials. Where it's successfully achieved, it is recognized as playing an important role in preventing the introduction of bias into your study. While a common feature of randomized control trials is the double blind, which neither the participants nor the researchers know what sort of intervention they are receiving. Blinding schools is sometimes very cumbersome because it might not be worth it delivering, say, a sham teacher training package if that's what you maybe thought of doing. So in many cases, it's not feasible to blind in a school context. This is an example of a school that participated in a study that was doing sun hats, but due to the due to the nature of the intervention being implemented, it was very difficult to blind schools their allocation, whether it's the control intervention group. As you can see in that example, the children are wearing their sun hats, and it's the first thing you're going to notice when you walk into that school. So, as a result, school trials may be susceptible to the Hofen Effect, as sometimes you're walking somewhere, you see yourself, like you're being watched, you end up behaving in ways that maybe you wouldn't have behaved in. So in the same manner, teachers and children may behave differently if they are constantly aware of their participation in the research program, which is commonly known as the Hofen Effect. Although this has been widely cited in research literature, further research on this subject should be a priority for trials conducted in the school context. The third challenge is in measuring important outcomes. Cluster randomized trials should set effect sizes in the context of the wider field. For example, you need to work out what outcomes could be relevant to the individual and what outcomes might be relevant to the schools. Example of outcomes relevant to schools may be staffing assessments, school governance assessments, etc. While those that might be relevant to the individual students could be things like building relationships, trust, or confidence within the students themselves. So you need to be aware of what outcomes are important to the population that you're working in. So measuring outcomes relevant to schools may guard against research fatigue. And research fatigue is a process in which individuals or groups tire of engaging in research or resist and avoid participation in any further research. So in order to guard against research fatigue, a common occurrence in cluster randomized trials, researchers need to prioritize evaluation tools that measure outcomes that are relevant and important, and in this case to both or to the different groups that are participating. This could be students as well as schools. So this will act as an incentive for the schools to continue participating in research, studies of educational interventions if they feel that the outcomes that matter to them are also being measured. So loss to follow up is the other challenge that we face when we do this sort of work.
To deliver the committee's recommendation.
Yes. The trial lecture has now been assessed and approved by the committee, and so the candidate may now proceed to the second part of the doctoral examination, which is the public defense of the thesis, which is in an hour or so.
Yes, congratulations.
Thank you.
And
Thank you very much.
The digital defense will start as announced at 12:15.
Thank you. Thank you very much.
Thank you, Atle, Nsangi, and the committee.
Thank
And
you.
we will see each other in 12:15.
Yes, we will.
Can I just confirm that my time is not the same as yours? Did you say 12:50?
Yes, 12:15 it is.
12:15, okay.
So it's in an hour.
In an hour, okay.
Yeah.
Good, see you soon.
Good.
Well, they have Norwegian time or your time.
Yeah, that's right.
What's your time?
My time now is 12:08.
Okay.
So I'm one hour
Oh,
ahead.
ahead of you.
Yeah. Okay.
Okay.
We will show. Present today is the candidate, the committee, and the audience. My name is Ulrike Hovet, and I will chair the digital defense. On 13 May 2020, Atle Nsangi submitted the following thesis to the Faculty of Medicine, University of Oslo, an educational intervention to enable children to assess claims about the benefits and harms of treatments. For evaluation for the degree of philosophy and doctor, the Dean appointed Professor Jimmy Volnik, Stellenbosch University, South Africa, Professor Kjell Sverre Pettersen, Oslo Met, Norway, Professor Astrid Klopstad-Wahl, University of Oslo, Norway, to evaluate the thesis, submit a report to the faculty, and evaluate the doctoral examination. Today, Associate Professor Anja Maria Lykke-Brand is acting as substitute chair of the evaluation committee. Following the recommendation of the committee, the Dean found the candidate's thesis worthy of defense for the degree of PhD at the University of Oslo. Earlier today, the candidate gave the trial lecture on the assigned subject, challenges of initiating and conducting randomized controlled trials in a school context. The trial lecture was passed. The candidate will now publicly defend the thesis. Professor Jimmy Volnik will act as first opponent and Professor Kjell Sverre Pettersen as second opponent. Anyone present at this public defense has the opportunity to oppose the thesis ex officio. If someone wants to do so, she must submit title, name, and his/her first question or comment via the chat function. Questions or comments ex editorial must be sent to me before the first opponent has finished his opposition. After the second opponent has finished his opposition, the audience will have the opportunity to ask general questions or comment on the candidate's work before we have a break and the committee retires to evaluate the candidate's defense. We will have a short break between the first and the second opponent. May I ask the candidate to share the screen and give an introductory presentation of her work. The word is yours, Alan.
Thank you. Okay, good afternoon everyone. My name is Atle Nsangi and I'm a PhD student here based at the University of Oslo and a health systems researcher based at Macquarie University College of Health Sciences. In this presentation, I'll talk to you about my PhD project that I've loved working on for the last 6 years. For the presentation outline, I'll take you through the introduction, the objectives and methods, findings before coming to a conclusion. So people are flooded with claims about treatment effects from a variety of information sources such as newspapers, TV adverts, and even sometimes personal conversations with family and friends. Many of those claims are usually unreliable, and yet people act on them all the time. So I'd like to inform you that the most powerful supplement on earth is also currently available in Uganda. So what do we mean by treatments? We mean anything from injections, vaccines, diet, exercise, food supplements, medical interventions, as well as medical equipment. So anything that is in that category we would refer to as treatments, anything we do to improve or maintain our health. So diverse evidence suggests that people's ability to appraise health information is generally poor. And while there's been some efforts to measure and improve people's ability to assess claims about treatment effects, most of them have primarily focused on health care professionals. There's been some sporadic efforts to fight misinformation that are cropping up from several organizations such as WHO, Africa Check, the Uganda Communications Commission is also currently started a myth-busting effort that fights against the epidemic of health information. So why is it that we are interested in children? First of all, we're capable of reaching a large segment of the population, and then teaching children critical thinking skills can lay a foundation to enable them assess health information and foster desirable dispositions while hindering uncritical beliefs. And if we don't address this now, Certain behaviors are very difficult to change as people go into adulthood. And as you're all aware, at some point these children will become parents, they'll be the future patients, as well as healthcare professionals and policymakers. So what was the aims for my study? One, we designed learning resources to enable children to understand and apply key concepts for critically assessing health claims. Two, we evaluated the effectiveness of these resources in a randomized trial. We explored factors affecting implementation, impact, scaling up, and any potential adverse or beneficial effects. And we also evaluated the effectiveness of the primary school learning resources 1 year post-intervention. So here is an example of one of the IHC key concepts that we introduced to the primary school children. And it says treatments can cause harms as well as benefits. The explanation is people often exaggerate the benefits of treatments and ignore or downplay harms. The implication is always consider the possibility that treatments may have harmful effects. However, very few effective treatments are 100% safe. And as some of you know, when people are desperate and hope that treatments will work, they tend to want to ignore potential harms. And as a result, a lot of money is wasted on treatments that have never been shown to be useful or effective, which may actually end up causing harm. And this is more so common now during the COVID pandemic. In these COVID times, many people are saying everything and anything that goes, and people in desperate situations are actually acting on that information. So this study was done in Uganda predominantly, and the study sites were located in 4 districts in which we conducted the evaluation of the primary school resources. So I would like to sort of give you a quick context of the area in which we did our study. First of all, Uganda has a population of about 46 million people. 50% of those are below the age of 15. The average teacher-student ratio is 1 to 69. Average age of grade 5 students is 11 years old. And the total annual government expenditure on education per child is $29 US per year. This therefore means that a significant proportion of this population in Uganda is actually still in school. Here is an example of a Ugandan class, children attending one of the classes or in one of the schools that participated in the evaluation of the primary school resources. And here is another one of them doing the evaluation, which we call or keep on referring to as the claim test, in one of the schools that participated. So what methods did we use in this study? For paper 1, we used a human-centered design approach that is characterized by multiple iterative cycles of development that start with engaging stakeholders early on in the study, participating in idea generation, prototyping, pilot and user testing, and then we collect feedback and do analysis, which the findings eventually feed back into the next version, and then the iteration starts. So it's a repeated process until it eventually culminates into a consensus on whatever final version of the materials that we'll be developing. So here is an example of pilot testing that happened at one of the schools, and in our earliest prototypes we tried out outdoor games to teach some of these IHC key concepts. But while we should note that the children had a lot of fun, teachers, especially in schools with large classrooms, an example of say 1 teacher to 200 children, were very overwhelmed. So they were completely overwhelmed due to the effort that was required to give children instructions, keep the lesson in order, manage to keep the time that was allocated for that particular lesson. It seemed like a very cumbersome exercise, but the children definitely had fun. And then the pilot testing happened not just in Uganda, but we tested the resources in 3 other countries, which included Norway, Kenya, and Rwanda. So here is some piloting happening in the Norwegian school. For paper 2, which was the evaluation of the informed healthcare resources, we assessed 2,960 schools for eligibility. Of those, 931 were considered ineligible for several reasons, which included either they could have participated in the user testing and piloting of the resources, or there were schools that were following an international curriculum, or there were schools for the disabled, or maybe there were schools that we considered far to reach. Those were schools that were found on the Kome Islands in Mukono that would have taken us more than a few days to get and come back. And then of those, we remained with 2,029, which were considered eligible to participate. 170 of those schools were randomly selected and invited to the recruitment meetings. 5 did not turn up for unknown reasons. We ended up with 120 schools that consented and accepted and were randomized. But the 45 schools that decided not to take part gave such several reasons, and one of the common one was the fact that they felt the school timetable is already too packed and they could not have time to do this sort of work. Others had other reasons, such as the people that came to attend the recruitment meetings were not the same that would make decisions on behalf of the school, so they decided not to make those decisions. We ended up with 120 schools consented and were randomized and randomly assigned to either the intervention or the comparison group or the control group. And after 9 weeks, they did what we call the claim test or the evaluation tool. And here at the end of the school term, both children in both groups completed this test. So some of the questions that the claim test had were, for example, in this case, there's this little girl called Habiba with her big brother Hassan, who says that, I once had pain in my ear and rinsed it with hot water, and the next day my ear pain was gone. So Habiba was asking Hassan what should she do, because she also had a similar problem. And Hassan said, so based on my experience, rinsing rinsing your ear with hot water might be painful. And then would ask, do you agree with Hassan? So the children would choose from the different options that are availed there. One could say, yes, because this is Hassan's experience, this is likely to be true. No, Hassan's experience is not enough to be sure, or Hassan rinsed his ear with hot water and the next day his ear pain was gone, so yes. So depending on whatever option the child felt that, would best answer that question, they'll choose that. The third study was the process evaluation, and here we used methods such as interviews, focus group discussions, observations, and lesson evaluation forms. And here we wanted to identify factors affecting, like scaling up and implementation of the intervention. So we purposely selected 6 of the schools in the intervention group, where we interviewed head teachers, children, and in addition, parents, 2 parents per school. But we also interviewed all the 4 district education officers for the districts that participated. This is an example of a joint interview of 2 of the grade 5 children. And then this is an example of a focus group discussion with the primary school teachers. Findings, 1, we were able to come up with a final set of resources that we managed to evaluate, and these resources include a comic book, an exercise book, charts, and a song, as well as a teacher's guide that helped to facilitate them in doing the lessons. Findings for paper 2, for the primary outcomes, which included the mean score, For the comparison schools or the control schools, the average score was 43%, while in the intervention schools it was 62%. In the comparison schools, out of 100 children, 27 managed to achieve a passing score, and this meant getting 13 out of the 24 questions correct. While if you compare it to the intervention schools, 69 per 100 children managed to achieve a passing score. And again, for the mastery, one child out of 100 in the control comparison schools, and 19 out of 100 in the intervention schools. Paper 3, the findings for the process evaluation were consistent with what we found in the trial, and most of the factors that we identified were actually facilitators and not barriers. We also did not observe any actual conflicts, and neither were they reported to us by the teachers or the students. So the students loved the materials, and the teachers found them compatible with the curriculum. Paper 4, the children did even better a year later in terms of what they had retained. But when we look at the primary outcome, again, in the year in the term that happened when the interventions were tested, 63 is what was the average score for children in the intervention arm. And again, a year later, it was 69%. So generally, there was an improvement in that group. And then 69 out of 100 children managed to get a passing score in the term that we did the intervention, and then 80 children out of 100 managed to get a passing score in the year later. The mastery score, 19 children out of 100 in the term immediately after the intervention, and again 30 children per 100 in the term in the year later. Strength, we used a human-centered design approach that resulted in resources that users tended to experience positively. We conducted a large cluster randomized trial with a 1-year follow-up that provided compelling evidence of the effectiveness of our intervention. And we used a multi-method approach that provided solid evidence for how and why the intervention worked. And we worked with a multidisciplinary team that was resourceful in more ways than one. Limitations. The outcome measure was aligned to the intervention, and as a result, it is inappropriate to compare the effect of our intervention on our outcome measure to the effects of other interventions of independent measures, such as reading or literacy or math. And again, we also used multiple choice questions to measure critical thinking skills that were only capable of measuring cognitive competencies but not dispositional characteristics, and who are also unable to measure the effects of this intervention on actual health choices and outcomes. Conclusion. First of all, I would like to conclude by saying that the IHC primary school resources were effective in teaching children to appraise health information. Using a user-centered design approach resulted in materials that the children, teachers, and parents found useful. They found them easy to use, credible, desirable, and well-suited for them. And then the major challenges we were able to uncover for scaling up included integrating the materials into the curriculum, but also the cost of printing the books. That's the end of the presentation, and thank you very much for listening to me.
Thank you, Nsangi, for your introduction. We will now continue with the opposition. I hereby call upon the first opponent, Professor Yemi Bonnik. The word is yours.
Thank you, Chair. First of all, Aaron, very pleased to meet you. And thank you for all the good work you've done. I really need to start on an appreciative note. I very much enjoyed reading your thesis, and I thought that specifically, I thought the research was well conceptualized and rigorously conducted, well analyzed. And I also thought that your findings were thoughtfully interpreted and also clearly reported. So all in all, I was very impressed with what I read. So thank you.
Thank you.
What I will do is, my questions will focus largely on the trial, leaving it to the other opponents to maybe expand beyond the trial. I will start with some fairly general issues, and then perhaps I have a few more specific questions for you. So to begin with, completing a PhD is usually a long and difficult process, and often it has a lot of ups and downs. So my first question really to you would be, and you hinted at this in one of the presentations, I think it's the last one you did, that you enjoyed your time in the last, I think, 6 years, you said. And so I want to know, and perhaps you could share with the audience, what was it specifically? What did you enjoy about it? And also perhaps mention some key challenges that you experienced. Not so much with the study, because you've already did a whole lecture on challenges in conducting, but personally, what did you enjoy? What do you feel the challenges were for you?
So, like I said, I think I enjoyed having been granted an opportunity to go back to primary school as an adult. And the fact that this took me back to a different time in my life where the issues that the primary school children are dealing with were not to the magnitude that we dealt with in the time we were in primary school. So while I went there being a little bit pessimistic about what sort of child is currently in the primary school and the teacher teaching them, especially now in the context of universal primary education, I was pleasantly surprised at how receptive children are, how they are capable of learning things that you might think are out of their league, and at how teachers have adapted to the numbers of the children they're dealing with at the moment. So that was something that surprised me but excited me, because I was reliving primary school but in a different context altogether. So I would say that that was something that I loved. And then the challenges would sort of be mostly not necessarily from working with the children themselves, but working with the teachers in primary schools, because of the low morale that most of these teachers have. I felt that most of the times I had to put myself in their shoes to be able to understand what they do and how they do it. But also, the other challenge was the fact that most of these schools currently are very under-resourced. And while we came up with these ideas that we felt were great, they might not have been issues that would definitely be on top priority in terms of the school or the educational context. So that was a little bit of a challenge, because sometimes when you'd introduce this work to a school head, you'd like to work with their school, and you say, there's this work that we'd like to do. Sometimes they'd say, why don't you do this instead? Why are you doing this? Because, this is what we think is important. But we managed to get around that by having intensive discussions with these teachers or whoever we were trying to engage. So those were some of the few challenges that I faced.
Thank you for that. So what we engaged in was an example of collaborative research. You work, typically collaborative research is when you work with a lot of people, and they come from different backgrounds. And so I guess I have two questions here. One is, Can you clarify for us what your specific role as a PI was in the trial? Because you work with a lot of people, but we want to know what is your role?
Okay. So I developed the trial protocol. I recruited the research participants. I trained the research assistants. I collected the data. I participated in sorting that data and cleaning up, ready for analysis. Of course, the data was analyzed by an independent statistician, and I also led the work on writing the manuscript. And the team supported me in terms of giving feedback on the manuscript, as well as comments on the protocol. So that, I would say, was my contribution.
Thank you. And in terms of what you think the main lessons are that you learned about collaborative research, what would those be?
Sorry, Jimmy, I didn't hear that question very well.
No problem. I'll repeat that. I'm looking at, what are the lessons that you think you've learned about conducting collaborative research through this process?
I think one of the important lessons that I've been able to learn as a result of that is that it's important for people to clearly understand what their roles are, because once you get them to understand, there's no much going back and forth in terms of what their contribution is supposed to be. And if you set out clearly with an understanding of what people's roles are, then it helps a lot in terms of saving the time that you spend in, addressing this is supposed to be in your docket or this isn't. So I think starting out being very clear is important. But also when you're working with several people, you need to be able to understand their strengths as well as their weaknesses, because then that helps you organize a team in a manner that is efficient. But then also you have to be mindful, or something that I've learned is being mindful of people's time, because we all have different priorities. So you have to work out a schedule that not only works for you as the PhD student, but also a schedule that works for all the other collaborators. So those are some of the lessons I've been able to learn.
So in your case, the team consisted of people from different parts of the world, but also people from different disciplinary backgrounds. And I would be surprised if there were not tensions developing from time to time. And did you have a sort of method of trying to resolve such tensions? Did you have rules of engagement of how one deals with issues of this kind?
Yeah, so I can't say that there were no tensions. Of course, there were not very many. But maybe some of the examples I would give is, when you're working not only in different time zones, but also coming from different contexts, sometimes the way you view, your world view might be different. So in one example that comes to mind was in regards to the development process. While there are things that seem to work in other contexts, but when you do bring them here, they don't. But I was blessed with a team, not only a team that I collaborated with, but once I was starting out, I formed what we call the Teachers Network. This was an independent team of 25 primary school teachers, that if there was something that the team that worked on the collaboration with me were not able to agree upon, we had an independent team that we could get back to and say, this is where we have failed, maybe to agree on the final version of this iteration. What would you say? So the teachers would act as the deal breakers. They would say, this is what needs to be done, or this is what needs to be done, and we'll take that direction. So I think that was very helpful.
Okay. I now want to just touch on the whole issue of critical thinking, because your trial aimed to teach primary school children to think critically. So can you share with us what your thoughts are about what critical thinking is, and how do you think that the intervention you evaluate might work to advance critical thinking?
So, critical thinking is generally defined as the reasonable, reflective way of thinking about what to do and when. So, there are several components within critical thinking that we think are important. For example, skepticism, problem solving, creative thinking. So there are so many other issues which critical thinking, the spectrum of critical thinking is based on. And in doing this work, engaging the children that we did, we wanted them to be able to be able to possess those skills, be able to ask questions, be able to sort of be skeptical about things that they're told or they hear, be able to look at information in an open-minded manner, be able to problem solve in case they're faced with an issue in their daily lives. So yeah, that's what we were trying to get at.
Are there any particular differences in terms of critical thinking that applies to making health-related decisions and just more broadly, critical thinking in general?
Yes, there are differences. There are differences in terms of when you're thinking about critical thinking broadly. There are some dispositions that would work again when you're thinking about critical thinking in terms of health. So those, although when it comes to the health perspective, you're focusing on health decisions, what to do or what not to do. But critical thinking in general, I think the different domains of critical thinking would be applicable to health, to critical thinking in health. So while there could be general broad terms, I think they would still be applicable in health when you're trying to make decisions, because you don't make health decisions independently of other things around you. So they are made in not just in relation to what treatment I'm going to use, but in relation to the context in which you are, whether that treatment is available or not, in relation to what sort of resources are available at your disposal, and the like. So while there are two different perspectives, critical thinking in general and critical thinking in regards to health decisions, they two still interlink in one way or the other, because critical thinking is a transferable skill that can not just be applied to one perspective, but to different perspectives.
Can you just expand a little bit more on the package, the intervention package, and what specifically it addressed? How did it move the agenda forward in terms of promoting the way people thought about health claims? Can you just specifically say, here is the package and this is the effect that we think it had?
So we first of all wanted to know if people even recognize that these claims are said or are out there. And when we were able to get the children to recognize these claims, we wanted them to be able to assess whether these claims are reliable or unreliable. And in doing that assessment, we thought that if they are faced with this decision in regards to their health, they will be able to make a judgment based on what information has been availed to them. So I would say that would be the process. You start out by recognizing the claim, if it's been made. Then you go ahead and assess the reliability of that claim, and then you make a judgment based on what has been availed. So that the end goal would be that you make a decision, hopefully, that is empowered.
So, perhaps just a few questions about the intervention itself. So one of the comments I read in one of your papers, I think it was the Lancet paper, where you speak about most Year 5 children in Uganda do not have English as their first language, and many have poor reading skills. But this being the case, that's the end of the quote, this being the case, you decided to use learning materials in English nevertheless. Yeah, I just wanted to understand what the thinking was about that. Why not use translated materials and teach, deliver the intervention in the language that the children were more comfortable?
Thank you very much. So there are several reasons why we ended up choosing to use English as the language of communication. One is because the primary school syllabus is taught in English, and especially for level grade 5, that's when schools are mandated to start their instruction in English. But also, so that was one of the reasons why we had to use English as the language of instruction in the materials. But also, in addition to that, Uganda is a diverse country with not just one language. As we speak, I think we have about 72 languages in the country. And Kampala, or the central region where we did most of the development work, is it's bilingual, multilingual context. So it would have been very difficult for us to zero in on a language of instruction that would be applicable to the entire population that we were hoping to develop materials for. So that directed us into that decision.
So I can understand now what the challenges were in trying to deliver the intervention in a particular language other than English in the school context. But did that make it more difficult to get the message across? So you had a multi-component intervention. Many different things were going on. You delivered it over a whole term to teach 12 concepts. Do you think that if you were just teaching a group of people in their own home language, you could have taught this more quicker, more easily, or don't you think so?
So that would be, I would say that would be very difficult for me to know. One, because generally these concepts were new, not just to the children, but to the teachers themselves. And while they needed not just to be able to understand them in terms of the language that was used, they also needed to understand the content, the concepts we're trying to explain. So I cannot really say for sure that if we had done that in a local language, it would have been better or faster. Because again, some of these concepts do not have an equivalent of the local translation. So while it would have been easier to explain them, say in Uganda, there are some things I would still have needed to explain in English. So and again, from the observations that were done in the primary schools, I realized that teachers were doing the instruction in both languages. So while they were communicating most of the content in English, in places where they felt that the children might not have understood or grasped the concept, they would use the local language, whatever local language was commonly used in that school. So that would sort of be, I think, the decision going forward in terms of choosing a language. I would suggest that whatever seems natural is what would work best. But in this case, it was both.
Thank you. And then in terms of the actual concepts that were being taught, my understanding of what I read is that prior research identified 32 concepts that were important to understand to be able to evaluate health claims. Of these, 24 were thought to be possible for children aged 10 to 12 to grasp. But then for pragmatic reasons, you selected 12 for teaching and evaluation in the trial. How did you end up with those 12 concepts? Can you just talk us a little bit through the process of getting to those 12?
So of course, we initially started out with a broad list, and we were not sure which of those key concepts would be relevant to the primary school children. But working with a small group, not a small group, but a group of teachers, about 25 of them, we came up with a criteria which included what sort of concepts we feel would be relevant, which sort of concepts we could be able to develop materials for, which sort of concepts would children be able to understand, and we also decided what sort of concepts, the children, which sort of concept the materials would be able to develop, being able to understand, being relevant, as well as the children would enjoy. So we started out with 24. Taking them into the schools. But when the pilot testing started, and we realized, first of all, how compact the school calendar or syllabus is, we noticed that teachers either had to rush through this 24 concept, which wasn't what we wanted, or would have to sit back and reprioritize which concepts would be important, or which sort of concepts would zero in. So we looked again at our criteria and decided that relevance is still important. Being able to develop materials is important, and understanding the concept is also important. And so the concepts that we decided to leave out the judgments were based on the fact that the primary 5 teachers felt the children needed more time to be able to understand those. So they were not yet at that level where the children were, and they would have been maybe have to repeat these lessons. So for those concepts that were considered a little bit difficult, we decided to retain for hopefully whenever we do the next version. So that's how we ended up with the 12.
So there was a specific reason you didn't just choose the 12 concepts randomly. There was actually a logic behind it in terms of what was feasible, let's say.
Yes, that's correct.
Yeah. Okay. Of course, 12 is only a small proportion of the original 32 concepts. And so I was a bit worried. So the 32 concepts that you said were necessary for making sound evaluations of health claims. In the first sentence of the Lancet paper, in the first sentence of the discussion, it says, use of the informed health choices primary school resources had a large effect on the ability of primary school children in Uganda to assess claims about treatment effect. And I just wanted to hear from you whether you think that statement is supported by the evidence from your trial.
Yes, I think it is.
Okay. So let me challenge you on this one, because if you start off by saying 32 concepts are needed to be able to make sound evaluation, you've only taught 12 of them. You can say that the children learned those 12 concepts, and you've shown that it is possible to teach those 12 concepts. But it seems to me that it's going beyond the evidence to say that you've taught them, you've shown that you can teach them enough to make sound claims of treatment effect.
Yeah.
So I'm just challenging you, and I'm not wanting to put you on the spot, but I just wanted you to respond to that.
I think that's a very good question, Jimmy. But like we said, I don't know if we mentioned that in the Lancet paper or in the paper before, where we talked about that list of key concepts. We say that this is not a list that is. So we say this is a list that's going to change. It's a living document. And while we reviewed the resources that we did, there was a likelihood that there are some concepts we could have missed out. So while we said that the list of 32 concepts is what people would need to understand in order to make good health decisions, that list is not set in stone. So we cannot conclusively say that unless you're able to understand those 32 key concepts, then I would say that going to be making very good decisions. So for the concepts that we taught the primary school children, the 12, I can say that yes, the children are able to make decisions based on those 12 concepts. However, we're not able to teach all the concepts that we had identified at the time for reasons that have been discussed in other papers. I think, for example, the time on the school curriculum would not permit that, but also some of those concepts were not at a level that children would be able to understand. But we also have to remember that while we were coming up with a list of key concepts relevant to children, we also wanted to relate it to their usual or daily life experiences. So some of these concepts were not yet in their daily life experiences and therefore would not have been relevant to those children.
Yeah, I agree with you. So it is true that the ability of the children has been improved to assess Hofen because it came from a zero base. So it is true that its ability, but there may be additional concepts that they would need to understand to perhaps make more advanced decisions.
Yes.
Well, I think you responded to that well, so thank you. Then, if I could then move on to another aspect, your trial monitored the delivery of the intervention, and that, of course, is a very good thing to monitor how the intervention is being delivered. My only question there was when I looked at how you did that. Again, I just want to use quotes. One of the investigators or research assistants observed one lesson in each of the classes in the intervention schools. And then you say, we observed how the teachers taught the lessons, but we did not provide feedback or advice to the teachers. So I guess my question here is, what's the purpose of monitoring the intervention delivery if there was going to be no attempt at correcting any problems that you detected? So, why bother?
So we ended up doing what we called the monitoring of how the schools had done the implementation from advice that we got at the Ministry of Education, where it's mandatory in quotes for at least a one-term visit once a new educational intervention has been introduced. So this is something that the teachers would have been used to and expecting to have happened. And based on that advice, we decided that we would monitor, but the monitoring that we did was not necessarily to intervene in sort of rectifying things or telling teachers what to do, but to fulfill that ministerial position that is usually done when new interventions are being introduced. So when we did do the monitoring, the teachers were aware that that happens. It's normal practice. It wasn't anything new, and we're not going to be giving them feedback, because when the ministry comes to monitor, they do not give them feedback, and sometimes they don't even give them prior notice that they'll be coming. So that's what we did, and that's the reason, or that was the reasoning behind it.
But what did you do with the information?
What did we do in the, sorry Jim, I didn't hear that.
Yeah, from the monitoring, how did you, yeah, I'm sorry, let me try again, I think the line was poor there. So you did the monitoring, you observed,
yeah,
and then what? It seems like nothing was done with the information, so that's why I'm asking the question, why bother?
So because this trial happened at the same time as the process evaluation, so we're also collecting observational data in terms of what was being done, how the lessons were being conducted. And in doing this, we're also monitoring fidelity and also addressing administrative issues that we'll be able to administer. For example, as a monitoring visit, you turn up at a school and realize that maybe they haven't had a lesson for 5 weeks. And the reason could be as simple as the librarian who keeps the books is away from school, so we don't have access to the textbooks. And that could be simply addressed as, you supply materials because the school did not have those. So the data that we're collecting as part of the observation contributed to the process evaluation data. It was for the trial use, not for the school.
I understand. So just a couple of questions about the tests. Your thesis has drawn attention to the fact that MCQs are not necessarily the best way to evaluate critical thinking. So my question is, why was this method of evaluation chosen? And were other approaches considered?
Yeah, there were other approaches that we could have used, but the reason why we ended up using multiple choice questions as an evaluation technique was to be able to measure this data objectively. And the second reason was because we realized while we were doing the Rash analysis in terms of validating the claim test, that children in this context do not have the capabilities of expressing themselves in an open-ended manner. Like if you ask a question and you ask them to answer it, because English is introduced at grade 5, most of them were not able to respond to what you are asking because they're not yet there in terms of their writing skills. But we were able to, because of their literacy, they were able to read and sort of be able to understand. They would make a choice that would be objectively measured. So that's how we ended up on the multiple choice question format instead of the open-ended questions that we could have used.
I think your paper says that it was not possible to directly evaluate how children actually make decisions about healthcare. Is that really true? Would it have been impossible to do that directly?
The reason why it would have been difficult to do that is because children generally do not make healthcare decisions in real life. So while we could have assumed that it's something that we can do, we do not really know if that would have been possible to do that.
Okay. What about a simulated situation? Was that considered? Was that tested?
Yeah, we asked them questions on self-behavior, but we cannot say that those are actual health decisions. So although they tried to answer that, we cannot relate that to being actual health decisions because they were not.
Okay. And then just one follow-up question on that part. The actual battery of questions that were asked in the multiple choice test, my understanding, and perhaps that's not correct, but was it the same questions at the end of term, which is the initial evaluation, and at the end of 1 year? Were they exactly the same questions?
Yes, they were.
And why was that?
The reason for that is because we wanted to see if children had been able to retain that knowledge, but also because those are the questions that had been validated for use in that age group. We also wanted to be able to measure if there's been any differences in terms of how they answered the first time round and how they did the second time round. So those were the reasons why we ended up using the same questionnaire. Although the arrangement of the questions was not exactly as it was the year before. So the questions had been sort of switched around.
Okay. All right, now about your findings. Your trial demonstrated unusually large effects which you yourself have written up and agree. One quote says, "We found a large effect, an increase of nearly 50% in the proportion of children with passing score. This corresponds to an effect size that was well above the average for other critical thinking interventions for any type of student in any country." So it seems we have been really an outlier in that respect. Do you want to just comment about why you think that effect is so large?
I think because the outcome measure that we use tended to measure knowledge based on what the children had learned and not on everyday standard tests, while the other studies that have been done in that area have measured based on standard tests such as math and literacy. So it's possible that we ended up with a large effect size because our study measured measured their knowledge based on the key concepts and not on the standard exams that the children do.
And is that different from all the other trials in this category?
Yeah, most trials that have been done in this area have measured based on standard tests, and those that have measured the same way that we did have also had large effect sizes, although not as large as we did have. So.
Okay. All right. So you correctly identified as a limitation of the study the number of children that didn't take the test, but at the end of the term, as well as at the end of the year, where the attrition was even bigger. And I just wanted to check with you, how do you think this attrition bias affected the validity of your findings?
I think the effect was negligible because on doing the sensitivity analysis, we still found that the performance did not really differ that much, even when we had lost some of the children as a result of attrition. So I would say that, yeah, it seems like it did not affect the results.
Do you want to say a little bit more about the sensitivity analysis that checked for this?
Yeah, so for the sensitivity analysis that we did, we looked at what sort of proportions. We used the lower and upper bound Lee proportions to see what sort of subjects. So first of all, the sensitivity analysis was suggested by the external reviewers in order to explore whether there was some risk of bias resulting from attrition. And we looked at what sort of performance the children that had not done the exams compared to the sort of performance that the children in the groups that had done the exams, to differentiate what their scores would have likely been using their academic performance.
Do you think that you could have done more to avoid or reduce attrition in the study?
I think that's a bit difficult to know what else we could have done to avoid attrition based on the fact that generally there's a lot of high dropout rates in schools in this context. So other than leaving it to the teachers or the primary schools themselves in managing how much the dropout they have, I don't think there's anything we could have been able to do in that regard.
But you do say in your papers that you think that the reason why more children completed the tests in the intervention groups, that group was more motivated to go follow through and do the test. So I just wondered whether there might have been something that could have been done to motivate the children in the control group.
So based on the information that we got from the process evaluation work, we found that teachers in the intervention arm were likely to encourage their students to sort of stay back, or at least ask for permission for when the test was going to be done, for the students to be allowed to do that test instead of being sent back home if they were unable to pay their school dues. But for the control schools, because we did not have an active control arm, it was difficult for teachers to be motivated since they hadn't taught these lessons. So although I would not recommend introducing an active control arm due to the challenges in sort of delivering a sham intervention in the control arm. I would say that I don't think there is much we would have done other than leaving it run the normal course as the school system runs.
Incentives or prizes, prizes is one form of incentive, but incentives in general sometimes are quite motivating in terms of getting people to return and do tests, and so could that have been an option for the schools, particularly the control schools?
It could have been an option if we were doing that as well for the intervention schools, but because we hadn't in any way motivated the intervention teachers, it won't be advisable to motivate the control teachers in that way, because then we would not be delivering the same intervention, or would be biasing those results.
Even if you're limited that to the encouragement to just complete the test at the end.
Unless we would have done that in the intervention arm as well. If we had encouraged the teachers in the intervention arm, then maybe we would do the same for the control schools. But because we had decided that the treatment arms would be treated the same way, other than for them having had the intervention, we did not feel that it was necessary for us to do that.
Okay. All right. So your trial focuses on the effects of an educational intervention on children's ability to assess health claims. However, we do know that knowledge and skills are not the only factors that are important for making good health care decisions. So my question is, in the Ugandan context, what other factors do you think influence the way people make health choices? And have you perhaps seen any of these being played out during the COVID-19 pandemic?
Yes, of course, there are several other factors that influence the way in which people make decisions, and some of them are cultural factors, social context, economic. So decisions are not based on just having good information, but there are other factors that play a part. And in the current COVID context, I think cultural factors as well as economic factors have played a huge part in terms of how people end up making decisions. And people's understanding of the disease, say the COVID-19 disease at the moment, is further steeped into their cultural background. And because, unlike other diseases that are seen easily, like someone has maybe a broken arm or has a skin rash, you can see. With COVID, I think people are still internalizing. So cultural factors play an important role, because while there are some public health measures that say social distance, but people are not seeing sick people, so they have no reason to go ahead and use that social distancing that you have said is what we would need to do to prevent them getting COVID. So decisions are made not just on information, but also on other factors as well.
Yeah. And sometimes they trump the information that you've provided or the knowledge that you've imparted. All right, so I'm almost done. I just wanted to ask 2 quick questions and then I'll finish up. One is scaling up. I think you've shown that, you know, this intervention, this education intervention to be effective, and ideally one would want to offer everybody this. So it's a scaling up process. What do you think are the barriers to scaling up, and do you have any suggestions for how they might be overcome?
So, first of all, there are several issues that pertain to scaling up, and one of them would be the cost of the intervention. If you base that on how much money is spent on a primary school child and how much the intervention spent, then that would be a huge challenge for government to undertake, because it would mean that a lot of resources would be required to be able to pull that off. But also, in addition to that, I think because these resources were outside of the primary school curriculum, it is difficult for teachers to see them as within the curriculum other than an add-on, which means that they might teach or use the materials as and when they feel appropriate. So I would say that those would be the major issues in regards to scaling up. But of course, there are other issues that we might maybe want to address when we do decide to scale up these interventions. For example, the issue of printing materials in the way that we did. Not only was it very costly, but also not sustainable in the long run, because as you know, these books would sort of get lost, or children would misplace them and the like. So we'd have to think about other ways in which these materials could be scaled up. Or maybe we would consider having, in case they're accepted as part of the curriculum, we would have to consider having them as tools that are supplied with the instructional materials that the National Curriculum Development Center sends out, but not as an independent textbook like we did.
It touches on my last question, which was, if you were to do the study all over again, what would you do differently? Anything you would do differently?
If I was to do it all over again, I think other than having a teacher's network, I would have an independent children's network. Of course, we were able to get information from the children by the user testing that we did. But I felt having a stable group of teachers giving you information, knowing from when the process started to the end goal, was very helpful. So I would have loved to have the same, a small group of maybe 20 or 25 children that we would start with from the beginning to the end. So that is what I would have done differently. But then also in terms of the materials, I think the textbook in this context, although it was very exciting to the primary school children, it's also very, very expensive. And while some schools would have loved to do this work independently of whether we provided the textbooks or not, that was a challenge. So we might consider doing materials that are digital for them to be able to use them as and when, instead of waiting on when these materials are supplied. So the delivery would also change, or the packaging of the materials would have to be rethought.
Thank you. Ellen, thank you very much. I think you've done some excellent work here, and thank you for being so patient with my questions, and all the best to you.
Thank you very much.
Thank you very much, Jimmy Bonnick, for an interesting opposition. No one has signified a wish to comment ex auditorio. So we will have a short break, 5 minutes, 35 minutes past, so that you're able to get some more energy. So we will meet 35 minutes past 1 o'clock. I now call upon the second opponent, Jens Petersen.
Okay.
We're missing Jimmy, it looks like.
Yeah, we're still missing Jimmy.
We will wait to find.
Yeah, Mats is phoning him right now.
Yeah.
It's probably appropriate to say good afternoon to you, Atle.
Good afternoon.
Yeah, well, I'm pleased to hear your discussion with Jimmy. So now it's my turn. As you probably see, Alan, I have made a couple of PowerPoint presentations just to let the questions and topics hang a bit. So,
Okay. Welcome back, Jimmy. Then it starts, and I know I call upon the second opponent, Jens Petersen. The word is yours.
thank you very much. But I want to thank you for having a pleasure to read and evaluate your doctoral dissertation. However, as you know, Alan, it is the opponent's job to search for and maybe find something to note. Description in the dissertation that are debatable, or descriptions that one thinks are in some way incomplete or even missing. But on that occasion, many of the important topics for the discussion have already been touched upon by the first opponent. But hopefully the topics I wanted to address now will also be interesting, both for the candidate and the audience. But first of all, I must say, this is a highly relevant project that you have been involved in. And it's also 4 solid papers, definitely. And it's a very interesting dissertation, easy to read and easy to understand as well. And as I understand, there's been a comprehensive collaboration between the partners involved. So all in all, it's a great job. Okay?
Thank you.
Yeah. So the first topic that I wanted to discuss with the candidate is, now that your project is completed and signed, sealed, delivered for that sake, in which field do you think this dissertation belongs? For example, is the content mainly about social medicine, health education, science education, social sciences, or pedagogy? Or?
So, thank you very much, Atle. I think it's sort of difficult to position this in one particular field because while we are aware that claims are not just made in terms in regards to health and health interventions or treatments, they could be applicable to all the other fields as well. So this is applicable to most of the fields that you have mentioned, but also in terms of pedagogy, I think that it's indeed applicable.
I think so. So it's strongly interdisciplinary, maybe.
Yeah.
Is that what you mean? So that you already answered that question, but that was the question I really want to raise. So the consequences of having such an interdisciplinary project, what could that be when it comes to writing the thesis?
I think the consequence would be in wanting to identify an area to which this thesis could belong. And when you try to do that, is you either have to choose what to leave out in order to fit in that one particular compartment. And as a result of it being broad-based and touching on several other fields, I think it's best left as something that could not just belong to one particular field, but...
yeah, exactly. So, the candidate, in fact, definitely, the candidate's dissertation could probably be characterized by having a mixed method approach. You agree with me on that one?
Yes, I do.
Yeah. So, whenever there's a mixed method approach, there is particularly challenging to, as I say, why did you not position yourself towards the epistemologies that you have applied to obtain the knowledge presented in the 4 scientific articles, especially in the synopsis or in the dissertation? Because as for now, I think that your dissertation is highly focused on what we call a medical paradigm when it comes to the presenting of the thesis. So you should probably position yourself towards the methodology or towards the epistemologies that were in use in order to explore the various research questions that you have used. So it's a little bit short on that note. Do you agree with me on that?
I think I do agree with you that I should have positioned myself, or I should have positioned this work towards the medical epistemologies. But like I said, because we were addressing different questions in the 4 papers, we had to approach it using different paradigms. And so, for example, I cannot say that this is where we would sort of lie, or this is where the study would fall, because we approached it from different contexts. As an example, for the development, we approached it from a pragmatic approach, where we also considered data that was subjective. While for the evaluation, we sort of approached it from a positivist sort of approach, where we considered objective data as having contributed to knowledge. So when you look at the different papers, they do come at you from different epistemologies.
Good, that's good. The next thing I wanted to focus on is the term treatment. The term treatment should have been discussed also in more detail, I think. But for example, there are some official definitions of the subjective specific term medical treatment. Aren't you agree with me on that one? So what is a treatment?
So for this particular work, we included anything that is done or used to improve or maintain health. Because we had not situated it just in the medical, in the clinical context, we tried to avoid the specific definitions that are laid out in that area, which is treatment as being anything, clinical interventions or surgeries and the like. So that term is still a term that seems easily, not just easily understood, but applicable to the sort of work that we were doing. Although we would have wanted to consider other terms, we did consider another term other than treatment, which was intervention. But that term was not interpreted in the same manner that this was in regards to what we were trying to teach children to do.
So are we mainly still talking about medical treatments in your work? Is it what it is? The 12 concepts or the 32 questions, in fact, are they all about medical treatments?
No, the concepts are not all about medical treatments, although some of them are about assessing the reliability of medical interventions or medical treatments. There are those that are not related to anything to do with medicine. For example, when we talk about things like opinions of experts can be from any field, whether medical or otherwise. When we talk about conflicts of interests, those can come from anyone or anybody or other than medical. So there are some concepts that do not specifically speak to the medical sense of treatment, but anything else.
Yeah. Okay, I'm satisfied with that. And now we come to some of the main questions that I have. Since your dissertation draws upon various epistemologies, we've been through that recently, and not at least uses young school children, year 5 pupils. Is that right? Year 5 pupils, they are of age 10 to 12 something. Isn't that right?
Yes, that's right.
Yeah, okay. I think that more study, now it should be more theory related to pedagogy, developmental psychology and the philosophy of science should have been presented. And perhaps specifically more theory about the nature of science, but I will come back to that later. But an essential theoretical aspect that should have been elaborated in the introduction part of the thesis is reflected by the question, to what extent are most pupils between the ages of 10 or 12 cognitively mature to possess critical thinking skills? Is it likely that pupils of that age group possesses higher order thinking skills, like analyzing, evaluating, or creating? You say something about it in your thesis, but what is your personal opinion?
I think,
despite from saying so.
I think when we look at the work by Jean Piaget of cognitive development, children at the age of 10 to 12 are at the cognitive stage of concrete operational, where they're able to not only communicate, but they can, at a certain extent, use reason and make deductions and inductions. While they are not yet adults, so they have not yet got to the formal stage of of having these skills concretized, they are in a position to start making certain decisions on a higher order thinking skill level.
Because I was a little bit surprised that you used 10 to 12-year-olds. Because normally when we talk about critical thinking skills or something, we think about adolescents probably. Because of the great variations of maturity, cognitively speaking, that exist among the 10 to 12-year-olds. Isn't it so? That's what I learned way back when.
And I do agree with you. Of course, there is variability in the skills amongst the 10 to 12 group, because, I mean, based on whatever background these children are or lived experiences, we don't expect them to be at the same level.
No.
Yeah, but again, they're at that stage where they're starting to use their reasoning, they're starting to think through things logically and make some sort of inferences. Although that skill has not yet been sharpened to a level of an adult, it's beginning, and I think it's the best time for us to intervene.
Yeah, you said so. Yes, I so far I agree, but did you experience great variations in maturity during your experimental research?
I would say that would be sort of difficult to measure what sort of variability existed, but from the interviews, if I go by that, I think I can say that it's there, but we didn't measure it to know how
No.
different the children are.
So the reason for using 10 to 12-year-olds was that you relied on literature saying that they were probably mature enough to be able to do this type of experimental research.
Yes.
Participate in it, I mean.
So yes, the literature supports that, but also we used a pragmatic approach in doing this work. So in our consultations with the primary school teachers, we weighed several options on what age group would be able to understand these concepts, but also which sort of primary school level would we be availed with time, access to the children as well to do this sort of work. So we did not just weigh their cognitive abilities, but also had to put into consideration the context in which we are working in.
Okay. I just wanted to ask you, are you familiar with these two concepts? What associations do you get when you see these two concepts? You have in your dissertation mentioned something about the scientific literacy, but probably not the nature of science. But in order for pupils to gain full insight, as I say, into the IHC, may it be relevant for them to learn something basic about scientific literacy, as well as the nature of science? I will come back to the definition of the nature of science if you're not familiar with this.
Okay. So I think in a way, in one way or the other, these two concepts are actually interlinked, because nature of science talks about how knowledge is generated, and this includes sort of investigative skills, while scientific literacy calls for creative thinking, problem solving, and the like. So, and critical thinking. So when you look at how knowledge is generated in the nature of science, and you're able to understand how information is generated, starting from observations onto going through that process as it happens all the way to doing the experiments, then you're able to apply the scientific literacy skills such as creativity and problem solving and the like. So I think that's how we interlinked.
Nice, very nice. Because I think that scientific literacy is exactly what you say. It's the knowledge and understanding of the scientific concept and processes required for personal decision making. And the reason for bringing up this is that I think it still has a clear link to what you have been studying, in such a way that do the pupils have any knowledge which might address scientific literacy as some kind of underlying knowledge before they even go further to be critical thinkers?
Yes, I do think there's some sort of underlying knowledge that the people already possess. And if you relate that to the Jean Piaget's theory of cognitive development, these children aged 10 to 5, aged 10 to 12 have already been through the initial stages. So in one way they are able to communicate, they are able to reason, and they do understand some concepts that would be introduced to them. So they have those basic skills, and it's upon those that we build up onto the other higher order thinking skills.
I just wonder, is scientific literacy, or especially the knowledge of scientific processes, as I say, on the bottom line, is it part of the curriculum?
Not necessarily at that level. At a higher level it is, but at the primary school level, the grade 5 level that we dealt with, it's mentioned but not explicitly sort of laid out on how that would be taught or introduced to that age group.
Exactly. So when it comes to health claims, medical claims. I will come back to it later as well, you probably imagine. So, is it possible that many of the pupils take it for granted that this knowledge is just factual, or it has pop up sometimes from experts or something, but the nature of science and the scientific literacy tells them that this is an ongoing process. It's a validation process. Definitely it's something very, very, very time-consuming before something becomes a fact, or definitely becomes a medical claim. You see what I mean? Because I think that many adolescents, to my experience, they are not aware of the nature of science. They are not aware of the scientific literacy, especially when it comes to the processes of negotiating knowledge before it became knowledge in textbooks, for instance.
Yeah. So I do agree that while nature of science sort of identifies the way in which science should be taught or introduced, not just in terms of scientific concepts being taught, but also in a lived experience in which people are able to understand these concepts based from their social environment. And while this has already been identified as important, most of the current curriculum on which the children are taught still emphasizes science that is taught not based from the environment in which the children are found, but from a classroom environment. So while it's important and children should be taught according to nature of science theory, that has not yet been put in practice because of the existing pedagogy being more of teacher-centered instead of child-centered. And with that, it is being in conflict with the nature of science theory because it emphasizes things like authoritative behavior, lecture, dictation of notes, and not being able to think outside of the classroom environment.
Okay. All right. I would also like to see examples of, in the dissertation of yours, the types of health claims that are usually presented to the public in society as present. And perhaps especially the types of claims that young people are particularly exposed to in various social media. Such claims are, however, rarely, I believe, of disease-preventing nature, but rather tends to be generally health-promoting, such as focusing on diet, obesity, physical activity. So, as I said, the word treatment gives probably a too strong association to the medical paradigm. So what I want to ask you is, which types of claims may young people be particularly exposed to in various social media at present? Is that on treatments, or is it something else? Is it health promotion, maybe?
I think in this particular context, it's both. So there's those that come as treatment claims and those that come as health promotion claims. But what would be a bit surprising here is that children in this context tend to pay more attention to claims that come in a medical or in a health treatment intervention context compared to those that come as health promotion. And that would be in relation to the cultural understanding of disease and well-being, where until there's a visible sign that someone's unwell, there's not much attention being paid to whatever condition they may have been facing or faced with. So they do tend to pay more attention to the other, which is the claims in relation to treatment interventions.
Yeah, okay. It could be a difference between, let's say, Norway and your country, because as I have experienced, it's a lot of focusing on health promotional claims, like, as I said, physical activity, obesity, not particularly diseases, but lifestyle issues. Because adolescents and young people, they don't feel that they get sick or need treatments at all. You see what I mean? So they are healthy, in fact, most of them, all the time.
Yes.
Okay. But the next question is probably a simple one. What is the distinction between what constitutes an ordinary health claim and a medical health claim?
So a medical health claim usually results out of empirical evidence that's being generated on a particular aspect of, say, whatever claim it is, that's supported by experts in that field. So that would constitute a medical claim, while an ordinary health claim is something that would be said without any sort of scientific or empirical evidence backing it.
What type of claims do you think dominates the social media?
I think while the medical claims tend to catch people's attention, I think it's the ordinary health claims that dominate the social media.
Do you think that young people are able to discriminate between what constitutes a health claim or a medical health claim? What kind of skills do they need in order to see the difference?
I think the sort of people that we worked with are not yet able to distinguish between an ordinary health claim and a medical health claim because they're not yet able to sort of make inferences and deductions as well as apply logical thinking in terms of weighing the different options or available options. So yeah, they will not be able to differentiate it.
Okay. Could it have something to do with maturity, or could it have something to do with what the school are teaching them? That's a stupid question, but I think you know what I mean. In your country, is it any focus on these particular things that there are health claims out there and are pretty few medical-based health claims out there? So do the school really emphasize what's the difference between these things?
I would say that the schools really do emphasize on the difference between those two things, but I also think we need to be cognizant of what sort of information is available here and what the sources of information are other than social media. The fact that we do not have, we have a very sort of low doctor-patient ratio. Most of these claims are not coming from the medical fraternity, other than people that practice, I would say, medicine, but in courts that sort of dominant in the population, because we are likely, we do have more traditional herbalists and other people in that line than we do medical doctors. So their claims sound out more than healthcare professional claims.
Okay, another simple question. Probably the former was not that simple, but what do you think about this one? In which school subject do you think that teaching approaches about IHC could be incorporated? You probably have already mentioned it, but could you mention it again, and why do you think it should be incorporated in a particular subject?
I think, of course, the reason why maybe it would be best to be incorporated in one subject be for logistical reasons, more or less. But I think that this should not, ideally, it should not just be incorporated into one subject per se, because these concepts are not just applicable to one particular study area. Although they sort of lend themselves to health, some of them, because we identified an area that children would be easy for children to understand. But these concepts are applicable to other subject areas as well. So the only consideration would be logistical. But otherwise, I would not say that this is the particular school subjects that they should be.
Exactly, because that's sometimes a difficult task to place such a teaching approach into a particular subject. Is it social science? Is it science? Is it health, education? What is it? So in the school curriculum, that might be difficulties, or which you probably already have experienced.
But yeah, I do agree with you on that. But also, not only would it be difficult to situate in which particular school subjects this would best be incorporated, but you also have to be mindful of how, what sort of content already exists in those particular subjects. Some school subjects do have more content than others. So while we would like to introduce these key concepts, we have to be mindful of where we can introduce what and when. So it would have to be put into consideration.
Okay. I will hurry up a bit because I have a lot of questions, in fact, but some of them are not that relevant. But is it like that critical operational skills of health claims and critical health literacy are overlapping to some extent? You say something about health literacy and particularly critical health literacy in your thesis, but not that much as I expected. So could you elaborate on this one? Is it possible that they are overlapping to some extent?
I do think that yes, there is some overlap. However, we should also recognize that one set builds onto the other. So while critical health literacy has certain skills like critical thinking, creative thinking, using, sort of being open-minded, being skeptical, and the like. I think you need to possess those skills in order to be able to critically appraise. So you build on those skills to do the other. So in a way, they do interlink.
Yeah, I have written more. I said that critical appraisal skills of health claims, well, to assess the trustworthiness, relevance, and results of published papers so that you can decide if they are believable or reliable and useful and so on. And I said that critical health literacy is all about the ability to critically analyze information and to use it, as I say. So I believe there's a great overlap between those two concepts. But as you say, the first one and the other one is probably very much interconnected, and they rely on each other in some way. So okay. Next one, sorry for being a little bit tricky here, but you mentioned something about doing what we call the Rash Analysis, which is modern test theory on the claim evaluation tools. And you say that it went out all right, and there was no, well, very few challenges on page 20 on your thesis, especially the one I received initially. And you also told Jimmy that you had statistical help from another person. So I just wanted to ask you, did you participate in this particular analysis when you tried to establish reliable test results from your claim evaluation tools? And the next one is interconnected also. How did the researchers arrive at the cutoff scores? Was it empirical or was it just deductive? Because whenever you try to establish some kind of tools based on psychometrics, it's very important that they have great validity. So that is simply what I'm talking about. Did you participate in this particular analysis?
So for the Rash Analysis, I wasn't the person that took lead in that work. However, I do know that there were some challenges that were seen, such as how the items acted, say on several functions like literacy, age, because remember we tested them not just in the school-going population, but also amongst adults with a primary level education, as well as adults with a background in health or health research. So there were challenges that some items were considered difficult or extremely difficult, while others did not acted differently in the different groups that we were looking at. However, I would still say that I did not take lead on the work of the analysis.
Well, that's a satisfying answer anyway. So the next one goes, well, did you inductively or deductively use the Nadelsky and Angoff methods? Because you could do it empirically as well. You could test out and find out what type of cutoff scores that such an instrument should have. But okay, that's also a tricky one. It will take a lot of time to go through it all in detail. But did you participate in that area also, or was it handed over to a collaborator or something?
It was an independent group of 8 judges that were not part of the IC group that ended up coming up with the cutoff scores. So they
okay. Well, I'm satisfied with that answer. So the next one is that the participating teachers' attitudes towards evidence-based health claims. What was your experience on that topic, and also the participating parents' attitudes towards evidence-based health claims? And the next one is that how great is the teacher autonomy in the classroom? Could it be so that there's a leading paradigm? So teachers might emphasize what they believe in and, well, maybe not emphasize as much the things that they don't believe in. For instance, if there's herbal medicine versus medical health claims or typical Western types of medicine contra I would say alternative medicine or something in your culture. Could it be so that the teachers themselves are bearing such worldviews that might have an impact on the teaching approaches? You have said something about it, but do you think that it might be a case that both teachers and parents might not have strong attitudes, positive attitudes towards medical health claims?
So teachers and parents are adults, as we know, and they've had some of these, like they've formed opinions over time, and sometimes they are difficult to change in terms of their attitudes towards evidence-based health claims and the like. But what we saw through this process is while teachers started out having, some sort of resistance towards this sort of work, we eventually saw it in how they answered the questions on the claim evaluation tool. So there were particular key concepts that would have been in conflict with their beliefs or attitudes, and they tended, of course, not to do as well in those key concepts. And one of them was in relation to treatments that have been used for a very long time, not being found a reliable way of assessing whether to use that or not. So teachers tended to struggle with that. With parents, because we did not, I did not directly engage them other than the interviews as well as the focus group discussions. Of course, just like teachers, there were also some key concepts that parents were very difficult to have their minds changed about. Yeah, so I can say that yes, there were those concepts
Yeah,
that they
exactly.
struggled to understand.
So I thought that it could be a challenge, despite the fact that it was a very popular project. I believe that deep inside the parents and the teachers as well, and probably also the students, they held alternative worldviews. Could it be the case?
Yeah, but although they did have those attitudes, they also managed to understand those concepts, because when you look at their scores on the claim evaluation tool, they actually did understand those concepts. It's just that they might have done better on others.
Yeah. I see it from my clock on the wall, and I just have 5 minutes left. So, well, about the Hofen Effect, you already had said so during your trial lecture, so I don't want to go into that once more. So I believe that the students themselves, they might believe or know that they were in the experimental work. Don't you think so?
Of course, I mean, they got the materials, so they knew that they were in the experimental group. But with children, unlike adults, it's difficult to know what sort of effect the Hofen would have on in the way they participate in research. So it would be very difficult for me to say for sure.
Yeah, I think so. I also think so. And I skip the next one. So I go on to the final pictures. Do 10 to 12-year-olds make decisions about what kind of health treatments they may need?
Yeah, I think yes. There are some minor decisions that ordinary 10 to 12-year-olds do make in regards to their health. However, we need to understand that this age group is not homogeneous. There are children that we consider children with special needs or chronic illnesses that do make important decisions. For example, in children with type 2 diabetes that have to constantly decide on when to take their insulin and when to have a meal, I think they do make important decisions based on.
Yeah. So what I was thinking about is that probably their parents who mainly takes such a decision, isn't it? So because they are not of age.
Yeah, of course, the parents do make most decisions, but there's those minor, for ordinary children, there are those minor decisions that they make, but the majority of important decisions are made. The majority of decisions and important decisions are made by the adults.
Yeah. So, okay, there's something about the paper 1 and paper 2, but I think I skipped that one for being polite with you. But finally, how to handle misconceptions of associations between body disease treatments and health among pupils? Is it something in the curriculum that says so? Because that's a typical science education approach to teaching. There's a lot of misconceptions about science, in fact. And could it also be an approach to discuss the misconceptions of the connection between body and health, for instance?
Maybe it would be something worthwhile considering, but as the current science curriculum is, the items you've listed are actually discussed as independent sections, and with some examples they could be related to each other. But like it is, because they are teaching children to regurgitate, it's easy, I think, to break them into smaller components for them to be able to understand them in those smaller components.
So is it any particular topic of science that is necessary to teach the pupils before they even go further to the IHC book? Do you think so? Is it necessary for them to have some basic science knowledge?
Yes and no. I think yes, because eventually they do acquire some of these basic skills as they grow in terms of their cognitive abilities. But I think it would be important not to emphasize that they would necessarily need to have these skills in order to learn these IHC concepts.
So very nice. Well, I have used my 45 minutes exactly, so I think I will finish up, and I will also finish up by saying something very simple, as they normally said in my early days when the movie ends. And they said the end. So thank you very much for a very fruitful and interesting discussion with me. Thank you.
You're welcome. You're welcome.
You have to unmute already, Kurt.
Thank you, Chancellor Petterson, for another very interesting opposition. And I now invite the audience to submit general questions or comments on the candidate's work. Please use the raise hand option in Zoom. And I already have got one question in chat from the clan Divine, and I'll give the word to you. Is it possible to get the clan Divine shown on the screen, Martin?
One more time, what did you say?
It's a participant that want to ask a question.
Yes.
Is it possible to see him on the screen?
Not unless I promote him to be a participant or analyst. I had some problems doing that last time, so it may not be possible.
Oh, but we can hear him.
Yes, we allow the person to talk. Who is it? Which one is it?
Ekran Divan.
If he can raise his hand, or he or she can raise their hand. Who is it again?
Oh yes.
Can you raise your hand? There we go. Someone's raised their hand now. So if you look in the participant list, the clan is number 2 in the list there. And if you allow him to talk, point to him and press allow to talk.
Yes. But he is not in our panelist.
Not the panelist, but attendees. Column.
Yes. Okay. And there is 2 more.
Yes. So you try the clan first.
Yes. And
Allow to talk.
And no.
Hello.
Yes.
No.
Hello. Thank you, and apologies if I submitted a comment to the wrong place. Alan, congratulations on a very interesting presentation, and what I thought was excellent responses to the questions you were asked. It struck me during the questions and answers that to conduct a piece of work like this requires a team effort, or it requires an individual who is an educational psychologist, a teacher, a child development psychologist, a trialist. The skill set that's required is really interdisciplinary to do this work really well. And I can see that your team, you have that expertise to pull from. It does raise questions for me, and this is not a comment about your PhD in particular, it's a broader question in terms of how we approach the conduct of PhDs within these broad interdisciplinary pieces of work, which require a team effort to deliver a good quality impact. But yet we have individual PhDs within there. I could almost imagine a scenario down the road where actually there's a team of PhDs being defending simultaneously, because it takes that team effort. And I do think it does challenge us as educators in how we are conducting this interdisciplinary work. Just a comment and just any thoughts.
Okay, do you want to give any comments, Alan? Not necessary.
Okay, no, I would not be able, because I mean, I've gone through this, so I would not be the best person to comment on that.
Okay. We have two more. And thank you, Claire. The next one, the name, it disappears, so you have to present yourself. I allow you to talk. The next guest. Yeah.
Can I? It's Ian Chalmers. Yeah, that's me. Thank you very much for the invitation to ask a question. But first of all, a comment. Thank you very much indeed, Alan, for presenting your work. When Daniel Semakula presented his work last week, my reaction to it was that it confirmed my decision never to do a PhD myself. And your presentation and the 5-6 years that you have spent working on this topic only reinforces that judgment that I made last week. My question relates to the attrition which Jimmy Volming questioned you about quite closely and raised some questions about whether the estimates of effect would be biased as a result of the attrition that happened, not only between the teaching of the material and the testing, the first testing, but also between the first testing and the second testing a year later. Those were important questions, but I look at it a slightly different way, and that is the two randomized cohorts that you established to do this work are incredibly important resources. Your heart will possibly sink when I ask you, have you thought about going back to these children when they're 2 or 3 to find out if you can still detect an effect of your intervention?
That would be very interesting for us to go back and see if there's any effects 3 or 2 years later. Although I may sound overly optimistic, I do think there's likely still going to be some sort of effect, even if it's a few years later, because they would not only have learned these concepts, but the idea of learning them was to be able to apply them in their daily lives. So if they're doing the application, they should be able to, we should be able to detect.
So do you have a personal motivation for seeking support to go and test that hypothesis or to estimate the possible effect of the teaching material? It just might give some information about how to reinforce the lessons that were learned as children go through school. Or maybe you'll be doing it in the studies that I know are being planned at the moment for older children.
I think, yeah, it would have been very interesting, and if that opportunity availed itself, it would be best to get that done. Of course, we do know that there would be so many challenges as a result of attrition, since most of the children, or not most, but a significant number would not have continue to the next level. So I would worry about what sort of numbers we are likely to be working.
Thank you very much, and best wishes for whatever comes next.
Thank you very much.
Thank you, Ian Chalmers. And we go on to the last one, Professor Sewankambo, and I'll give you the word. Professor Sewankambo, you have to unmute.
You have asked him to, you have clicked ask to unmute on him?
Yes, I have done that, but
Okay.
Okay.
There we go. He's unused now.
Okay. Sewankambo, the word is yours.
No, it's Ian who's unmuted now.
Yes. Thank you very much, Alan, for a very exciting presentation and discussion. The discussion was great. I really enjoyed this. So it is just to say thank you very much for putting up such a good presentation and discussion. Yes, as Ian has said, I think there should be motivation to follow up on his children and see how they stand at this point in time a few years down the road. I thank you.
Thank you. Thank you very much, Nelson.
Thank you, Sewankambo. Then I don't have any more. It seems no, it's no one more. So then I say thank you, and we will now have a break while the evaluation committee retires to discuss the candidates' defense. So I will ask the committee members to go to the other room. And we will be back in a while. I will now call on the committee chair to deliver the committee's recommendation.
Well, as committee chair, it's a great pleasure to congratulate the candidate with the defense of your thesis, and the committee will deliver a recommendation to the Dean of the Medical Faculty that your PhD examination with the public defense of your thesis should be approved.
Thank you. Thank you very much.
Congratulations.
Thank you very much.
I know. Yeah, congratulations.
Thank you.
I now will call on the candidate for some concluding remarks.
Thank
The
you.
word is yours.
Okay. Thank you very much, the panel, for today. And I'd also like to thank the Informed Healthcare Choices team that did work collaboratively with us on this work. I would also like to thank some colleagues here at Macquarie University College of Health Sciences and colleagues at the Norwegian, the University of Oslo, as well as the Norwegian Institute of Public Health. I'd like to thank my family and friends who have been here and supported me as well. And lastly but not least, I'd like to thank my supervisors, Atle, Andy, and Nelson. Thank you so much for all the effort that went into this work. Thank you.
Okay, the faculty will receive a report of today's public defense.
Thank you.
On behalf of the Faculty of Medicine at the University of Oslo, I would like to thank the opponents and the committee chair for their service on the committee and their participation in today's doctoral examination. On behalf of the faculty, I congratulate you, Nsangi, with a successful defense.
Thank you.
I also wish to extend congratulations to the supervisors and the candidates' research leader. Thank you to the IT department and the technicians for their assistance. And hereby I declare the public defense concluded. Disputatio parenta est.
Thank you.
Well done, Alan.
Thank you very much. Thank you. Thanks everyone.
Since the disputation has taken place digitally, we will now continue with a short informal part. I would like to, yes, and it's now possible to give some brief greetings to the candidate from co-workers, colleagues, family and friends. Please use the raise hand option.
I can also promote them if they want to turn on their videos.
Yes,
Yeah.
that's nice. Perhaps it's nobody prepared.
There is Andy Oxman there.
Okay,
We'll allow to talk first. Andy, shall I promote you so that you can turn on your video?
Only if you want to do it.
Okay, there we go.
When you are logging in, put a
Okay, Andy, you can turn on your screen,
There you go.
there we go.
Well done, Alan. Congratulations. We're all very proud of you.
Thank you very much. Thank you, Andy.
And thank you to the committee for doing such a wonderful job. Thank you.
Thank you.
Yes.
Thank you very much.
That is nice. Die Blockchain, Symbol der Blockchain.
Congratulations, Atle.
Thank
We are
you.
proud of you.
Thank you very much, Jackie. Thank you.
okay. Have you had some more? You had some more hands up, Morten?
Gisha, shall we allow her to talk? Shall we allow her to talk? And Michelle? Yeah.
Yeah. It seems like Ellen would. Yeah. Okay.
Michelle, do you want me to allow you or promote you to a panelist so that you can turn on your screen? Hello, Michelle? Michael, it is, possibly?
Hi, can you hear me?
We can. Shall we turn
Yes,
on?
I just want to congratulate Alan for his successful defense and her work is inspiring us master presentation in that field and so I really want to congratulate her and the entire team for paving the way for our career. So thank you so much. Congratulations, Alan.
Thank you very much, Michael.
You have was that the last one?
Angela, should we ask her to unmute?
Yes, do that.
Okay, Angela, you can unmute yourself. Angela Musuka.
Okay. Is it trouble getting her? How
Congratulations, Atle. This is Mommy, Juliet Sechuan and Dr. Richard Sechuan. Greetings from Elizabeth. Come in and say congratulations to Mommy.
Congratulations, Mommy!
Thank you. Thank you very much, Elizabeth, and thank you, Mom and Dad, for that. Hi, Jeremiah. Thank you. I'll wave back. Thank you, guys.
okay, very nice.
I think Angela also has a microphone on now.
Yeah.
They want to come with their congratulations.
Okay. Okay, is it someone there that want to congratulate?
Congratulations, Aunt Atle. Say congratulations, Aunt Atle.
Congratulations, Aunt Atle.
Thank you very much, girls. Thank you very much, girls.
Okay. I can see it as a congratulation on the chat too. You see it, Alan?
Yes, I do. Thank you very much. Thank you, everyone who sent me those messages.
Then should we end the informal part, Alan?
Yes?
You said okay, yeah.
Yeah.
Then I'd like to end the informal part and personally congratulate you, Alan Nsangi, on a well-conducted dissertation.
Thank you.
And I think we will stop here
Thank you very much.
and ask the technicians to close down the Zoom. Thank you.
Thank you very much. Bye-bye.
Leave now.